Our time now in Manila is 9:05 a.m. We had some technical difficulties earlier, but I'm hoping we've ironed that out. I'm speaking from the video conference room of UP Manila in Padre Faura. Welcome to all our participants. I don't know how many are logged on, but I know we have more than 111 registered on GoToWebinar and a lot of people also joining us via live stream. Today's speaker is Dr. Leo Anthony Selly, currently Assistant Professor of the Harvard Medical School, Clinical Research Director, Laboratory of Computational Physiology, Institute of Medical Engineering and Science, Harvard, Massachusetts Institute of Technology, or the MIT Division of Health Science and Technology. He is also course faculty for Global Health Informatics to improve the quality of health care at the Harvard MIT, course faculty for the secondary analysis of electronic health records of Harvard MIT. He is the lead of SANA, Institute for Medical Engineering and Science, Harvard MIT. He is the lead for MIT Critical Data, Institute of Medical Engineering and Science, Harvard MIT. He is a principal research scientist of Harvard MIT, staff physician of critical care in Beth Israel Deaconess Medical Center. Dr. Leo Selly is a graduate of the University of the Philippines College of Medicine, class of 1990, who finished his residency in internal medicine at the Cleveland Clinic, his infectious disease fellowship at Harvard Medical School, his fellowship in critical care medicine at Stanford, and fellowship in medical informatics at the Massachusetts General Hospital. He obtained a science master's degree in biomedical informatics at the MIT and a master's in public health at Harvard Medical School. May we now call on Dr. Selly.
Hi, can you hear me?
Yes, I can hear you.
Hopefully, yes. Good. Salamat, Pauline. Okay, I could see my first slide, and I'm going to move on to my next slide. Just for disclosures, I have no conflict of interest relevant to this presentation, but our group receives research funding from the National Institute of Health, Philips Healthcare, SAP, Amazon, and Microsoft. I wanted to give an introduction about our group first before plunging into the talk for this morning. So next slide, please. Our group is called the Laboratory of Computational Physiology, and we have three big arms, umbrella arms, and these are MIT Critical Data, SANA, and PhysioNet. So MIT Critical Data is actually an international consortium of people who are interested in secondary analysis of electronic health records. We use the phrase secondary analysis because primary analysis pertains to the use of the health data for the care of the patient. And secondary analysis is when you aggregate these electronic health records and you do analysis to perform population studies or to develop prediction algorithms. And that is referred to as secondary analysis. And MIT Critical Data is really a group of colleagues, not just from MIT, but across the country as well as across the globe, who are interested in this area of research. Pauline mentioned about a course on secondary analysis of electronic health records that actually starts this Friday. We will be streaming the lectures for free over a YouTube channel. So if you're interested, just let me know and we will give you the link to the private YouTube channel. And this will continue throughout the semester, so through December 9, I believe, for this year. And the idea behind the course is to team up clinicians, so not just doctors, but nurses and pharmacists with data scientists so that together they could interrogate databases made from electronic health records to answer clinical questions or to develop predictive algorithms. We actually wrote and will be publishing a textbook. The textbook is also going to be open access, so it's of no cost. I think it will be online by October 3rd, and you just go to this website and you will have access to the electronic version of the entire textbook. but the hard copy is going to be not free, but the electronic version is free at any time. So we made sure that we had an open access license for this book. Next slide, please. On top of the course, we have been organizing what we call datathons, and datathons are a very short, intense version of the course. It typically runs over a weekend. We start on a Friday night, and clinicians pitch research questions, and then data scientists would form teams with the clinicians, and over the weekend, they perform data analysis. And where typically the faculty would be there to mentor the different teams. If they encounter a roadblock, we help them troubleshoot. Like if they don't know how to find a certain variable, we help them. And then we also coach them in terms of the study design. So we have been organizing datathons all over the world. We're hoping to go to the Philippines at one point. This coming year, we will be in Beijing. In October, we will be in London in December, then we will be in Melbourne, Australia in March. And again, the idea here is to get people interested in secondary analysis of electronic health records. We have also obtained a database coming from Philips. So this database is much bigger than the one that we have now. The one that we have right now is called MIMIC, and it's a database obtained from patients admitted to Beth Israel Deaconess Medical Center, which is the ICU where I work at. But starting this year, we were assigned the role of being the curator of this much larger database with over 2 million patients from across the United States. And it has all the data being collected from an ICU patient. So the data coming from the bedside monitor, the nursing flow sheet, all the notes that are captured electronically. And then we update this with survival data. So we actually buy death records from the United States government, so we could indicate in the database whether the patient is still alive or not, and if they died, how long after their discharge did they pass away. So you could perform survival analysis, look at the impact of different interventions, including medications, by interrogating the database. Our goal is to scale this database to become international. So we have been talking to partners from around the world. Belgium is the first country that has created a similar type of database. They're calling it the Matrix database. At this point, we have also partnered with hospitals from other countries, including the Albert Einstein Hospital in Sao Paulo in Brazil, hospitals in Australia and New Zealand, and then a number of hospitals in the UK, as well as the APHP in France. And what we'd like to do is to build this giant international database and make it available to as many investigators from around the world. Next slide. The other project that I had mentioned is called SANA. Some of you are familiar with SANA. This is focused on designing and implementing and evaluating digital health information systems. So what we'd like to do is also perform health data analytics in low and middle income countries, but most of the time you don't have a full set of electronic health records, especially in the rural areas. So what we're doing is to leverage the ubiquity of cell phones so that you could capture health data in digital format and also create databases that would be useful for research purposes later on. To help us with the projects in SANA, we've been running a course called Global Health Informatics to Improve Quality of Care. We've had 6 iterations of the course now, and the lectures, they are also streamed online for free. We are now actually preparing a massive open online course that will appear on edX in February of 2017. So people could actually register and get MITx or edX credits for taking the class. And this is a lot of work. We had to go through 6 years worth of recorded videos and put that into a narrative so that we could teach global health informatics to tens of thousands of students. Next slide. For this course, we also finished writing a textbook. I think some of you in the audience were authors for this textbook, and this textbook is going to be published by MIT Press. Also, completely open access, free of charge to the students. And the idea here is to bring together clinicians with software developers so that they could design together software as well as electronic health record systems for any clinical application that you're interested in. And next slide. So my last slide about what we do is this slide showing some of the ongoing projects that we have for SANA. So we partner with universities, with nonprofit organizations, with governments, and we have really a very wide range of clinical applications for which we are using the SANA platform, which is an open source mobile platform for use for capture of data, also for decision support for community health workers. And that's the last slide for talking about what we do here at MIT and at Harvard. So now the main topic, which is the perils of observational studies. Next slide. So we start off with this page out of Harrison's 1978 edition. And for some of you in the audience, you're familiar with Harrison, which is the Bible of internal medicine. And if you look at the textbook way back in 1978, this is what it says for how to manage someone with a heart attack, how to manage myocardial infarction. And the prescription are as follows. The patient is not allowed to have any activity for 6 weeks. They're not even allowed to go to the toilet for 2 weeks. Beta blockers are to be avoided for heart attacks. You have to start everyone on lidocaine to suppress ectopic beats and to avoid any arrhythmias. And you cannot take the patient to the cath lab because they say that angiography is dangerous because the plaque is too unstable. So for the internists out there, we know that none of this is being followed now. This is all recommendations that have been thrown out of the window. Next slide. And this is an example of what we refer to as medical pendulum. So this is very common in medicine for the practicing clinicians out there. We have all these guidelines and recommendations that would change every decade or even sometimes every few years. So this would pertain to treatment or test considered beneficial 1 decade is no longer deemed valuable or even harmful the next decade. And I've listed here some examples for those people who work in the intensive care unit. Pulmonary artery catheterization used to be a standard practice when I was training as a resident, but now we hardly do them in the medical intensive care unit. Estrogen replacement used to be the rule for women after menopause, and we all believe that estrogen would prevent heart disease among women after menopause. And now prospective randomized controlled trials have disproven that, and that's no longer the recommendation. And the third one was tight control of blood sugar among those with type 2 diabetes. Prior to 2008, we thought that if we normalize their HbA1c or their blood sugar control, we thought that that provides the patient with the best prevention for complications from type 2 diabetes. But the ACCORD trial was published in 2008, and it actually showed a increased trend towards higher mortality for type 2 diabetics whose blood sugars were tightly controlled. So again, there was a shift in the attitude towards how to manage patients. And these are all examples of the medical pendulum. Next slide. At the start of the summer, this paper was published. It's from a guy that I idolize, John Unitas. And this paper, I think, came out in June of this year in PLOS Medicine. And it's a similar theme as his previous work. And this one is entitled, Why Most Clinical Research is Not Useful. And I'm going to refer to this article again sometime later. Before we jump to the perils of observational studies, I wanted to start off that, yes, we do consider prospective randomized controlled trials as the gold standard, but this is not without perils either. And I'm going to highlight a few examples where we've we were mistaken with prospective randomized controlled trials. So this first study that I'm going to highlight was published in JAMA at the turn of the century. It reports that the use of Tamiflu in treating acute influenza reduced the duration of illness by 30% and the severity of illness by 40%. And in the discussion, they said that this could potentially cut down hospitalization rates among high-risk groups. And this was in JAMA, which is one of the highest impact medical journal. A few months after that, in Lancet this time, another journal with one of the highest impact factor, published another study looking at the benefits of Tamiflu. And this one reported a randomized controlled trial that demonstrated the benefits of Tamiflu in terms of alleviation of symptoms, decreased viral load, as well as improvement in health and activity. So this was widely embraced. These were prospective randomized controlled trials. They were peer-reviewed in the top journals. So everyone thought that, yes, this is to be, this should be the guidelines for the treatment of acute influenza. And because of these studies, when there was some paranoia about a pandemic happening because of the bird flu, governments actually started stockpiling Tamiflu and Relenza so that we would prevent what happened in 1918. So governments bought billions of dollars worth of Tamiflu and Relenza based on the studies that were published in high impact journals, and these were randomized controlled trials. Next slide. At around 2008, there were some doubts, some concerns that maybe we did not get to see all the studies that were done using Tamiflu and Relenza, and there was a demand for the pharmaceutical companies to release all the studies that were performed looking at how effective are these medications for influenza. And the British Medical Journal actually demanded Roche and wrote an open letter to the CEO of Roche that for the sake of public health, we would like to request you to release to us all the studies. And after a few years of debate and arguments, finally, both pharmaceutical companies that make Relenza and Tamiflu provided to the Cochrane group the full reports of 20 Tamiflu studies and 26 Relenza trials. So it turned out that only 4 trials were published out of all the trials that were performed. And after looking at all these prospective randomized controlled trials and putting them all together, the final conclusion is that the only benefit that you could get from taking these medications in acute influenza is that you reduce the symptoms by half a day. There was no evidence that it reduces hospitalization. There was no evidence that it reduces mortality. There was no evidence that this medication would actually prevent person-to-person spread of the virus. This was a jarring report. It turned out that we wasted all our money in stockpiling with Tamiflu and Relenza, that the trials that were published in high-impact journals turned out to be a small biased sample of all the studies that they have performed. So my point here is that just because a prospective randomized controlled trial was performed and got published in a top journal, it doesn't mean that that becomes the ground truth. So going back to the article that I flashed earlier from John Unitas at the start of the summer, why most clinical research is not useful, one of the things that he looked at in his paper is he looked at the median sample size for randomized controlled trials in 2006. And as you know, the bigger the sample size, the better it is in terms of power to detect an effect size. And looking at all the randomized controlled trials that were published in 2006, they found that the median sample size was 36 per arm, 36 patients per treatment arm or in the control group. And how were they able to get away with this? Like, looking at this now, people would say, those are all bullshit studies if they only had 36 patients per arm. Like, how can we trust that? And the way the investigators usually say that this is enough patients is that instead of looking at an outcome that we're really interested in, say, for example, death or survival, they start using surrogate outcomes. Oh, let's look at, I don't know, duration of mechanical ventilation instead of looking at death, or let's look at the amount of blood transfusion instead of looking at whether they survive the bleeding episode or not. So a lot of the studies would use non-validated surrogate outcomes, or a trick that's common among the cardiology trials is they use composite outcomes. So let's look at, if we add the complications from heart failure with atrial fibrillation and death, let's see if the total of that composite outcome is different across the groups. And sometimes the outcomes that they put together are actually not that relevant to the outcome that we're really interested in. And this is how they managed to rationalize why they only had a small number of patients per arm. So you have to be careful. Don't just read the abstract of a prospective randomized controlled trials. We have to really learn how to be more meticulous in terms of looking at their methodology, in terms of looking at whether the study is really powered enough to detect an effect size that is clinically relevant. Next slide. And the problem is not, next slide please, the problem is not limited to randomized controlled trials. In this paper, John Unitas actually said that most of the time observational studies add even more confusion rather than fill information gaps. And meta-analysis, which is where you combine different prospective randomized controlled trials, systematic reviews, and guidelines, cannot really salvage the situation and often add their own problems and biases. So you look at this, you read this paper, and you think that we're all fucked. How are we supposed to practice medicine when we cannot rely on clinical research? Next slide. With that, I wanted to plunge into the perils of observational studies. So observational studies, as you know, would be even more complicated in terms of performing analysis because there was no experimentation done. There was no flipping of a toss coin to assign patients to different treatments. Observational studies is merely analyzing what we have, and now with the advent of electronic health records, a lot of observational studies are being performed on data that's being routinely collected from the care of patients. And I'm gonna go over some studies that will highlight some of the dangers or some of the errors that are typically committed in the performance of observational studies. Next slide. So this first study touted the benefits of immunizing the elderly in the community against influenza. First of all, I'm not saying that there are no benefits from influenza vaccination. I do believe that there is value in vaccinating elderly people as well as immunocompromised people in the community. What I'm saying here is that the initial study that they used to back up that recommendation was flawed. So in this study, they claimed that they were able to confirm that influenza vaccination is beneficial for reducing hospitalization and death among community-dwelling elderly patients over a 10-year period. But when you start looking at the patients who had vaccine, so what they did was they compared the outcomes of patients who got the vaccine versus the patients who did not get the vaccine. But the patients were not randomized. They just looked at the records and identified those who got the vaccine versus those who did not get the vaccine, compared their hospitalization rates, and they found that the hospitalization rates and the death rates were lower among those who got vaccinated. So in the next slide, what we found out when you scrutinized their data even more was that the patients who got the vaccine were very different from the patients who did not get the vaccine. The patients who got the vaccine were more likely to be physically independent. They were more likely to have quit smoking. they were more likely to be on statins, they were more likely to have pneumovax. So if you're going to be doing an observational study, you cannot just compare those two groups of patients. You have to adjust for all these confounding variables. So this is the healthy user bias. It's a type of a selection bias. And here, in this study, it was nicely pointed out that the people who got the vaccine were healthier to begin with, and that could be the reason why they had better outcomes. We move on to another study. Again, I'm not saying that this study was used by the RAND Corporation to convince the Obama administration that electronic health records is the way to go. I'm not saying that we should go back to paper-based system. I'm saying electronic health records is definitely the way to go, but the initial study that they based that recommendation on was flawed. So what they did was they studied the patients who were cared for in institutions that had electronic health records. They compared them to patients who were cared for in institutions that did not have electronic health records, that were still using paper-based charts. And they examined the records of more than 27,000 patients with diabetes. And what they found is that the patients who were being cared for by doctors using electronic health records had better outcomes. And they made claims that if we roll out the use of electronic health records in the United States, that we would be saving $77 billion, we would be improving the lives of patients. If you learn something from the first example, your first question now should be, are the patients who were cared for by doctors using electronic health records, are they similar to the patients who were cared for by doctors using paper-based systems? And the first thing that they looked at when we scrutinized the study is, let's look at the doctors first. Are the doctors who are using electronic health records different from the doctors who are using paper records? And the answer is a resounding yes. The doctors who were using electronic health records were younger, they were more likely to be in an academic center, they were more likely to be in a large hospital. And not only that, when we started looking at the patients being cared for by these two different types of doctors, the patients again were very different. The patients who were cared for by the younger doctors tend to be white, they tend to be higher socioeconomic status, they tended to be less sick. And that completely invalidates the findings of the study. You cannot compare those two types of patients because they're very different to begin with. So this is what we refer to as comparing apples to oranges. You cannot do that. In order to see the effect of a treatment, you have to apply them to apples and apples so that you will know the effect of a treatment. You cannot give one treatment to apples and give the other treatment to oranges and see and measure the difference in the effect. Next slide. And when they realized their mistake, a lot of people pointed out that your study was flawed. They actually recanted their paper. They said that they think that their earlier projections for the benefit of electronic health records based on how it impacted the care of diabetic patients was being overly optimistic and based on less than adequate evidence. So they realized that it was a flawed study. This one is from way back in 1987. This one got published in the New England Journal of Medicine, which is the highest impact clinical journal. And here the authors said, by studying just the records, they said that patients who are being given benzodiazepines for sleep are more likely to fracture their hips. And it makes sense. If you're a clinician, it makes sense that if you give them sleeping pills, they're going to wake up in the middle of the night, they're going to be drowsy, and they're going to fall, and they're going to break their hips. And because of this study, some of the states here in the United States actually became more restrictive in the use of sleeping pills or benzodiazepines in nursing homes. Again, if you learn something from my previous examples, your first question would be, are people who are prescribed benzodiazepines, are they the same as people who are not being prescribed benzodiazepines? And you probably have guess the answer. Next slide. And the answer is a resounding no. They're very different. The people who are getting benzodiazepines for sleep tend to be sicker, they tend to be older, they have other things that are different from those patients who are not being prescribed benzodiazepines. And the way that they were able to refute that study, next slide, is by performing what we call time series studies. But here, what I mentioned earlier, that some states became more restrictive in prescription of benzodiazepines. So New York State became more restrictive. And in this slide, you could show what happened to the use of benzodiazepines after institution of a policy that they will try to stop the use of benzodiazepines for sleep. So the graph above shows what happened in New York State, and you could see a marked drop in the use of benzodiazepines. The graph below showed what happened in New Jersey where no such policy was instituted. And there's not a significant, there's some drop in the use of benzodiazepines, but not as much as was seen in New York State. But what happened with the incidence of hip fracture between the two states? So if the study was correct, we should see a drop in hip fractures in New York State. But what we found is that there was no difference between New York State and New Jersey State, even though New York State markedly reduced their use of benzodiazepines in nursing homes. And that officially debunked the findings of that study published in the New England Journal of Medicine. And the last example I'm going to give of an observational study that is flawed, next slide, was looking at the campaign to improve patient safety. So this campaign recommended the use of checklists. Again, I'm not saying that those are wrong. I think that these are very worthy quality improvement initiatives, but the study that they used to promote it was flawed. So this is back in 2006. The media actually caught on right away. They said that a campaign to reduce lethal errors and unnecessary deaths in U.S. hospitals has saved an estimated 122,000 lives in the last 18 months. And they were saying that we in healthcare have never seen or experienced anything like this. And it was widely applauded, the results of the studies. And I'll show you the trend in the drop in preventable deaths. So here in this slide, you could see that from 2004 to 2010, there is definitely a marked reduction in the deaths from preventable harm. And these are typically deaths from drug-drug interaction, deaths from hospital-acquired infections, deaths from performing the surgery on the wrong part of the body because of the institution of checklists. But the question is, what was happening to these rates before the quality improvement initiative was implemented? And you could see that in the next slide. And it turned out that the trend was already dropping, even before the quality improvement initiative was launched. And this is an example of a strong time series design that controlled for history bias. So this is what we refer to as the history bias. We unearthed this data from the work of the Agency for Healthcare Research and Quality. Again, I'm not saying that quality improvement initiatives to improve patient safety is wrong. The study that they used to promote it was definitely flawed. And the problem gets worse with big data. With big data, we tend to inflate the effect size, or not really inflate the effect size, but we inflate the significance. So this is a paper that landed in Nature, one of the highest impact science journals. And what it said is that online daters do better in the marriage compared to couples who meet in the traditional manner. And their sample size is very large. They surveyed more than 19,000 couples. And what they found is that the couples who met online are less likely to divorce, with a p-value of less than 0.002, and the couples who met online are also happier with a p-value of 0.001. So if you only look at the p-values, you would think that you would be convinced that the way to meet your wife or your husband is to find him or her online. But when you start reading the actual paper, this is actually the observed effect size. What they compared was the divorce rate, which was 6% for couples who met online versus 7.7% in the traditional. But when you calculate the p-value because of the large sample size, this turned out to be a p-value of less than 0.002. And the way that they gauge happiness was to have them rate their happiness on a scale from 1 to 7. And the average score for the couples who met online was 5.6, and the average score for the couples who met in a traditional manner was 5.5. So to me, I'm not convinced looking at this data. But when they reported a p-value of less than 0.001, that the couples were happier, if you're just reading the abstract, you will be fully convinced about their findings. So this becomes a major issue once you start working with data sets with tens of thousands or even millions of patients, and you have to be very careful. Obviously, I believe in observational studies, but we have to do it right. I gave you examples of how we could be mistaken when we perform observational studies. For the clinicians out there, I urge you to work with statisticians, epidemiologists, and machine learning people if you want to perform this type of studies. But is there any reason to believe that we could actually trust observational studies? Next slide. And the answer is actually yes. So there has been some studies comparing observational studies with randomized controlled trials. This paper actually comes from John Unitas, who I've alluded to before, and his group found a significant correlation between the treatment effects in randomized controlled trials versus observational studies across 45 diverse topics in general internal medicine. And last year, the Cochrane group also studied and compared randomized controlled trials and observational studies, and they found no significant difference in the effect estimates regardless of the observational study sign or heterogeneity. This is what I was referring to before, the curse of observational studies. You have to make sure that you're comparing similar patients so that if you see a difference in outcome, you will ascribe that to the treatment rather than to the inherent differences in the patients who got the treatment versus the patients who did not get the treatment or the patients who got another form of treatment. I might end it there so that we will have time for discussion. I wanted to go over some of the methods used to adjust for confounding, but I wanted to give ample time for some interaction. So what I'll do is, let's move on to the very last slide, and then I'm just going to show the very last slide. And the last slide is just saying that you have to beware, you have to be cautious about the p-value. It's not enough just to look at the p-value. At the start of the year, the American Statistical Association released statements on how to use the p-value correctly. And they're very strict now. You cannot just report the p-values. You have to report your effect size, obviously. You have to report your confidence intervals. You have to report all the assumptions that you made to test the null hypothesis, because all it really tells you is the probability that the real world, the effect in the real world is at least as big as what you have observed in your study if the null hypothesis were true and if all your assumptions in looking at the null hypothesis are correct. So they're saying that you shouldn't be basing your practice based on one study, that you have to really look at the totality of evidence and not just look at the p-value. So I'm going to end it there, and I'll turn it over to the moderator, and I think there's going to be a response, and we'll open it up for question and answer. Thank you.
Okay, thank you for that lecture, Dr. Selly. We would like also to thank today's sponsor, Manila Doctors Hospital and the Makati Medical Center. Our reactor today is Dr. Rolando Enrique Domingo from the UP College of Medicine class of 1992. He is a Master of Science candidate in clinical epidemiology, currently working on his thesis. He is our technical reviewer at the Centro Oftalmológico Jose Rizal and is currently Section Chief of Ocular Pathology and Oncology of the Department of Ophthalmology and Visual Sciences, Philippine General Hospital. He was our former PGH Medical Director. He finished his residency in ophthalmology at PGH and is fellowship trained in ophthalmic pathology and oncology at the Universidad de Valladolid. May we call on Dr. Domingo.
Thank you, Pauline. Hi, Leo. I'm Eric Domingo. I was a few years behind you in high school and med school, so you've been famous to me for the last 30 years. I'm a student of clinical epidemiology and not in any way an expert, so my comments and some questions might be a little elementary to you, but I hope you'll give it some time. Thank you very much for that wonderful talk. It really expands our understanding of observational studies and how to appreciate them better. We've always been taught that RCTs, I mean, at least the good RCTs, are superior to observational studies because of the inherent weaknesses of the latter. We all know that they have a lot of limitations when it comes to bias and variables that are not controlled. But sometimes, especially in our local settings, observational studies are the best that we have, or maybe the only studies that we have. I believe observational studies can still be useful when an RCT may be difficult to perform, like when we have ethical limitations or expense problems, or the variables simply cannot be controlled. And it is in these situations where improved analysis of observational data is important, and this is maybe where you can help us a lot with. One argument for observational studies is that they are real-world studies, and if they are performed and interpreted correctly, then they can be very helpful in actual practice and in actual situations, especially within the setting that it was being done. As you discussed, at the very least, observational studies can give us information that points to the right direction regarding the hypothesis. Even if the magnitude of the effect might not be that accurate, at least it gives us a clear idea of whether the hypothesis, if the hypothesis can be accepted or rejected, or some direction that we go that can help us design future better studies and drive randomized trials. But when observational studies are all you have, do you have any tips for us on how we can systematically appraise them and choose which ones are actually better than the rest? Do you have a special checklist that you use, or do you use the same tool as you use when you appraise other clinical studies? How can you help us, decide when we read an observational study if this is a relatively good one or really just garbage? And also, I was looking forward to you talking about some secondary examination of data from observational studies.
That's another webinar.
Which Pauline just told me is going to be another webinar, because I was wanting to hear your thoughts on how to choose studies that are good for, observational studies that are good for secondary examination, and how you limit the bias and the subjectivity of it. Because if you look at it, sometimes I feel like it might be like doing an observational study on an observational study when some covariates and confounders are not really identified. So I really would like to hear your thoughts on that.
There's definitely a lot of agreement between our opinions, and my first answer is how do we prevent those studies from dominating the literature? And one approach that we have been advocating, we're big proponents of, is opening the data and being very transparent with your methodologies. One thing that we have been doing, so as I described earlier, we have open databases, and what we're trying to do is to completely change the way we do research. What we're trying to build now is a research community that is more critical of each other, that is open to being criticized and being corrected, that's more encouraging of other people to try to repeat the studies, especially with with secondary analysis of electronic health records. And it would be a different approach. So at present, the different groups who are working on the same topics are typically fighting each other in terms of funding. They don't publish how they perform an experiment, and there's really no push for replication. So one of the hottest topics right now is the irreproducibility of research, and I think I've talked about that in the past. And to us, the way to address that is that we have to be open in terms of being scrutinized in terms of our methodology, and we have to push for other people independently repeating our studies. So I remember reading a paper just recently saying that you should not believe any study that has not been replicated, because chances are it's probably 50-50 whether it's correct or not. And the course that we're doing is not just going to be a pipeline of new studies. We will also have groups of people there who all they're going to be doing is repeating the studies from the previous semester to see if things were done right. We're also encouraging all the people working in our database that when they publish, they submit their notebooks. So their notebooks are typically a collection of their codes that are being uploaded on GitHub. It has a Jupyter notebook. It has all the logs of their discussions around the methodology, around the selection of the patient cohort, around the definition of the inclusion and exclusion criteria. And we encourage people to publish this so that when they read a paper and they have some issues with some of the results, they could really scrutinize what you did. And when they say that, oh, you shouldn't have done this, your definition of ARDS is wrong, then we encourage people, well, let's repeat it then. And let's now incorporate some of your questions. And let's see whether we could have the same results. And if the results are the same, despite tweaking some of the methodology, in turn, what you did were sensitivity analysis. And it really looks at the robustness of your findings. So this is an approach that we're actively pushing for. We think that research groups have to be more open to each other, have to be more collaborative, have to be more cooperative. We're checking each other, making sure that the methodologies that we use were sound, and we're open to being corrected. Like I love to find out if you think some of my papers were garbage. I need to know why you think it's garbage, and I'd like to repeat those studies. So I think this is our safeguard against being infiltrated. As more and more data becomes available, as more and more people are analyzing the data, the biggest concern is that we're going to have bigger data, we're going to have bigger noise. And we need to really figure out what are the true signals among the noise. And the only way to do that, I think, is changing our attitude, our culture around research.
Okay. Thank you very much, Leo. That's a very insightful response to Dr. Domingo's comment. We're starting to get a lot of questions in. Let me just acknowledge our attendees. We have more than 65 logged on the webinar platform. 30 on via live stream. No? 30 are logged on via live stream. We have friends from the Philippines, of course, United States, Germany, France, and even Slovakia. Welcome to the webinar. We have I can see around 18 from the RBE auditorium at the Centro. And I think in Palo, I can count around 8 who can fit in the camera of the computer. So we're opening the microphones of the satellite sites so they can ask their questions. Just raise your hand and we'll acknowledge you. Let me read some of the questions that came in through the chat box. One question is from Dr. Imelda Ang. I'm assuming she's Dr. Imelda Ang. How do you assess that a surrogate outcome or composite outcomes are valid?
It has to be assessed by the clinicians who work in that field. And that should come from the domain experts. So from a cardiologist's point of view, what are the valid outcomes for someone with heart failure? It's just looking at the daily weights. Is that a valid outcome? Like if you prove that the weights are stable and they're not gaining weight as a result of congestive heart failure. Is that a valid surrogate outcome? Typically, you go for a surrogate outcome if you think that the effect size is small. So when you look at mortality, it has to be the impact on mortality has to be large enough if you only have 1,000 patients in each arm. And sometimes the impact on mortality is not that big. And the way to address that is to either increase the sample size, and you've seen cardiology studies with 30,000 in each arm, or choose a surrogate outcome that is easier to see the difference in. But ultimately, the decision whether that surrogate outcome is valid will depend on the clinicians who are in that specialty.
Okay, very good. But there's another question from Dr. Nestor Pamatmat. I think he's our classmate, if I'm not mistaken. What are the best ways of dealing with observer biases in observational methods of research?
You have to adjust for them. I wanted to include that ways of adjusting for confounders in this talk, but we didn't have time. So I promise that the slides that we didn't go through today, I will include in the next webinar. And just as a preview, there are different ways of adjusting for these confounders. So the most common one is doing a regression. So you include the variables that you think will confound the relationship of your exposure with the outcome. But there are other ways. There are some people who say that regression and adjusting for confounders may not be enough. So there's also what we call propensity score analysis. And I will go over these methods in the next webinar sometime in November. And in propensity score analysis, you actually adjust for the patient's propensity to get a certain treatment. So I'd like to give a good example. One of the papers that we published looked at whether an arterial line adds value to a patient who gets admitted to the intensive care unit. But the patients who got an arterial line are very different from the people who did not get an arterial line. So what we did was we developed a propensity score that will represent the likelihood that a person will get an arterial line. And each patient now gets a score, and you compare two patients who got the same score, but one patient got an arterial line and the other patient did not get an arterial line. So that's your propensity score analysis. And the last methodology is instrumental variable analysis, which is a bit more complicated. But I'm going to go over these methods in adjusting for confounders in my webinar in November.
Okay, I have a follow-up question from Dr. Ang. She is a cardiologist, so she reads a lot of studies with composite outcomes. Her follow-up question is the use of the composite outcomes valid?
It's controversial. Some are valid, some are not. So each component of the composite outcome should be a good surrogate outcome. And again, typically you do that if you think that your study is not powered enough to look at each individual outcome, because the effect on each individual outcome is not big enough, and you're going to need 100,000 patients in each arm to show a difference in one individual outcome. So what they've done is, well, let's put together 5 outcomes, and maybe if we add them all up, we could see a difference between the 2 arms. So my answer there is, they're less trustworthy if you're looking at composite outcomes compared to a study where you only have 1 outcome. And each component of the composite outcome should be valid surrogate outcome for the illness or the disease that you're studying.
Okay, there's a question from Dr. Eileen Dualan. What do you think about the strobe guidelines or checklist?
In a lot of the papers that I publish, we say that we follow the strobe guidelines, so it's highly recommended to make sure that you follow the checklist in performance of an observational study. So yes, I highly recommend it. If you're going to do that, make sure that you go through the guidelines and then you write in your paper that you follow the strobe guidelines in the performance of your observational study.
Okay, and then there's a comment from Dr. Duwalan. The best ways to deal with design, study well, regression, stratification.
Yes, and
Okay.
hopefully we could discuss that more in November.
Okay, then Dr. Sarmiento, Dr. Raymond Sarmiento has a question. Secondary analysis of available data from previous clinical trials are already being done in the bioinformatics field. The laboratory of Atul Bhute, formerly of Stanford, comes to mind, and they often discovered new associations on variables that were not formally investigated in previous clinical trials. The question is, how do you think findings from secondary analysis of EHRs will change the way clinical practice guidelines are developed?
So some people would say that secondary analysis are merely hypothesis generating, and that you should follow it up with randomized controlled trials. And I think that's a valid statement. But the problem is that we cannot perform a randomized controlled trial for every question that we have, for every subgroup of patient, because it's just way too expensive. So basically right now the way we make decisions is that yes, we follow a guideline based on a randomized controlled trial if it exists. If it doesn't, you use your gut instinct. What I think is going to happen in the future is that if you have a question and there's no answer based on a randomized controlled trial, you will have the capacity to interrogate the database and look for patients who are similar to your patient, and then compare the ones who got treatment A versus treatment B to help you decide whether you should give treatment A to this patient. So I think that we will see an increasing role in secondary analysis of electronic health records to complement the intuition, the clinician intuition. What we've learned over the past decade is that clinician intuition is not always correct. We have so many cognitive biases. The way we think is different at 3 o'clock in the morning versus 3 o'clock in the afternoon. It's also clouded by what we were exposed to the week before. It's also clouded by our experiences with, especially the bad experiences would influence some of our decisions. So there's a lot of subjectivity in the way we make decisions now. And maybe if we have some help from computer algorithms who are interrogating the database, maybe we'll have a better approach to clinical decision making. We've written papers describing this. A group also described this approach. They call it the green room. We call it I forgot what we call it, but we wrote another paper, but we kind of wrote it at the same time, but it's describing exactly this approach. I think we call it the DCBM methodology. And Raymond, I'm happy to send you those papers, but I think this is going to be the electronic health record of the future. So you're not just able to document what's happening to the patient. You have the capability of looking at similar patients in the past whose records are stored in your system.
There's another question from Dr. Sarmiento. What is your opinion on archive, ARXIV, or bioarchive, like repositories being part of the culture for biomedical scientists, which obviously is a paradigm started by physicists?
We're going to see more of this. I think this is going to be the standard in the future. I mean, data sharing, I think there's a push for data sharing. This is the only way to really leverage the power of data. There will be more and more data integration across different fields. For example, in genomics, that's already happening with the Global Alliance for Genomics in Health that's spearheaded by the Broad Institute. And what they're building really is this repositories of not just genomic data, but they're integrating that with clinical health records data, and they're sharing it to investigators around the world. So the division that I've described I'm hoping will be a reality in the future.
And Dr. Sarmiento confirms it's DCDM. Okay, there's a comment from Twitter that came in using hashtag unreliable research. Turns out that the perils of observational research involves RCTs also.
Yes, I completely agree. And the problem with RCTs, and I didn't talk about it now, I've talked about this before, is that it's highly tainted by conflict of interest. 60% of trials being published are sponsored by drug companies and medical device companies. So you have to be very careful. As soon as I see that there's funding from a drug company or a medical device company, I take it with a grain of salt. Like, even if I trust the authors, sometimes you start doubting of how objective were they in the performance of those trials.
Okay, let me, as we wait for more questions, let me go through some of the answers to the pretest we gave our registrants via GoToWebinar. There were 4 true or false questions. The only statement that's true is number 2, which says causation cannot be established from observational studies. The other statements that are false include current evidence-based medicine is mostly based on randomized clinical trial. It is also false to say that the generalizability of observational studies is always inferior to that of randomized clinical trials. And comparing outcomes of patients whose physicians use electronic medical records with patients whose physicians use pen and paper medical record is valid. So the only statement that is true is statement number 2. For the multiple choice question, the selection bias in health-related interventional study includes letter A, which is healthy user bias. I don't know if Leo, Dr. Selly still wants to comment on those pretest questions we gave our attendees.
No, I wrote them, so I'm not going to comment.
Okay, there's another question. Wait, let me just go to my screen that has a question. Good day, sir. You mentioned earlier online free courses on critical data course and global health informatics. Could you enlighten us some more about them? This is a question from Dr. Ellery Ivan Apolinario.
I think the easiest is to email me if you're interested, or wait, erase that. The best way to find out how to get the link for the streaming videos, or for the when we archive it, how to get how to access those videos, is to go to our website, which is criticaldata, one word, .mit.edu. Again, criticaldata.mit.edu, and we will have instructions there. We didn't want to just post it in public in YouTube because we were afraid that it's going to be reposted and it's not going to have the right context. So we're going to keep it in a private channel, but anyone who's interested in it will have access to it. And then the textbook is called Secondary Analysis of Health Records. It's in Springer. It's going to be open access starting October 3rd, so anyone could access the electronic version. If you buy it, it's $60, but the electronic version is completely free. So that's the course in Secondary Analysis of Electronic Health Records. The SANA course is in February. So Raymond was a speaker in our SANA course like 2 years ago. That's also streamed live, and you could find instructions on how to connect in our SANA website, which is sana.mit.edu. And it will appear on edX. So that's probably a better way, so you could do it on your own time. And you could get an edX, an MITx credit at the end, starting in February. So we're now creating that MITx course. But if you could wait for that, I think it will be worthwhile. For the next few months, just focus on the Secondary Analysis of Health Records course.
Okay, there's another question. Do patients need to give consent before their data for EHR can be used in research?
That's a very controversial question. I am not in favor for patients giving consent. I am in favor for patients opting out. If you're going to opt out, though, then you shouldn't also be benefiting from research. Like you could opt out, but I mean, we're doing this to improve the care of everyone. So if there's a group of you who's going to be, it's almost like I will receive an organ transplant, but I refuse to give my organs. It's almost like unfair. If you're going to be benefiting from research, then you should be contributing your records. So in other countries, there's an opt-out method. They could actually say that I don't want my records to be included in any research. And that's perfectly fine with me. The problem is when 60% of the population starts saying that I don't want my records. So just know that if there are any recommendations based on analysis of records, it probably won't apply to you because you pulled out your record before the analysis was performed. So my simple answer is I'm not in favor of every patient consenting every time their records is being used. I'm in favor of opting out if you really feel strongly about your data being used for the purpose of quality improvement, for the purpose of medical research.
Data will remain anonymized, is it?
Yes, yes. So all our data is completely anonymized, but for informatics people out there, they say that you could never fully anonymize data, that there's some way of figuring out who that person is or re-identifying a patient. But to me, the bigger the database, it's going to be harder and harder. If you have a database of 10 people, and Pauline, you're one of those patients, I think I could find out who you are among those 10 people. But if you have a database with billions of patients, I think it's going to be very difficult for me to find your records there. So, I mean, talking about anonymization, de-identification, privacy and security, I think merits a completely separate webinar. I could talk for hours again in that topic, but I forgot the question already. but
the question was the patient need consent. The question was about consent for your data.
Yes, yes.
The next question is, the Philippines is not yet into electronic health records, but we are starting to encourage registries. Do you have any advice to maintain data validity in these registries? This question is from Dr. Imelda Ang.
I'm in favor of registries. They're better than nothing. To me, they're not as good as electronic health record data, and the reason for that is in registries, you select the variables that you're going to collect, and sometimes when you perform a study and you wanted to adjust for a certain variable that is not included in the registry, then you're stuck. If you have an electronic health record database, then, oh, we need to adjust for this, then you may do so because that data is typically available. But for registries, there are tons of registries out there. It's definitely very resource intensive to maintain them because most of the time they require nurses or doctors to enter the data manually, and it's hard to do that and scale the project because you're very much dependent on a person also doing their job correctly versus an electronic health record data where it's automatically extracted from the machines, from the different systems. That's easier to scale up. And that's why, as I said, with the Philips database, we're collecting data from 2 to 3 million patients, and not really having a limit in terms of the variables that we're collecting. So yes, they have a function, but I think the age of registries are going to be superseded by the age of electronic health record databases.
And I think this is a final comment from Dr. Duwalan, Eileen Duwalan. There's a legal distinction between de-identifying and anonymizing data, and the correct term that we should use for our health records is de-identifying data.
I agree because, as I said earlier, it's not full anonymization that happens. But yeah, the idea is the same though. Like what we want is not to be able to be identified. The purpose of anonymization is that no one can pick out your record or no one could search for you when they start interrogating the database. But I agree completely that there has to be a separation of the terms anonymization and de-identification.
Okay, so let me summarize what I've learned. Most of this take-home message came from our pre-test questions that current evidence-based medicine is based on best available research evidence and not just randomized clinical trial. Causation cannot be established from observational studies. Leia, correct me if I got this wrong. The generalizability of observational studies is not necessarily always inferior to that of randomized clinical trials. And comparing outcomes of patients whose physicians use electronic medical records with patients whose physicians use pen and paper medical record is not valid. And selection bias in health-related interventional study includes our healthy user bias.
I agree, yes.
Okay, all right. Okay, then thank you for that engaging discussion, Dr. Selly and Dr. Domingo. Thank you for your comments. Thank you, everybody, for your participation in this webinar. Please submit the proof of your webinar attendance to our email here, seminar1.selly@gmail.com. You need to answer a post-webinar evaluation so that we can send you your certificate of attendance. Whether or not you need your PMA-CMB units, you might want to get your certificate of attendance. There are upcoming webinars. Dr. Domingo is lecturing on October 4 on handling client complaints on social media. This is happening October 4, 9 a.m. Manila. I think all our attendees who registered, you will get this link for registration for Dr. Selly's webinar. Dr. Leia Selly's Part 2 webinar is happening on November 4. The slides we didn't take up today. He promised to show us on the second webinar, Unleashing the Power of Health Data Secondary Analysis of EMRs. It's happening November 4 at 9 a.m. Manila time. And then as part of the UP Med webinar series, there's another lecture by Dr. Gary Lorenzo on novel therapies for lung cancer happening September 28 at 12 noon Manila time. In behalf of the webinar team, thank you for joining us. We hope to see you again in our upcoming webinars. Please invite your colleagues to join our community for this ongoing webinar series. On behalf of the Philippine Eye Research Institute, the UP class of 1990, the UP College of Medicine, we also thank our collaborator units, UP Manila Information Management Service, the UP College of Medicine Postgraduate Institute of Medicine, Medical Informatics Unit, the Asia eHealth Network, DOST, AST, and of course, Ms. Charisse Orhalo, our host. This is Class 90, yay Leo. And we would like to thank our sponsors as well, Manila Doctors Hospital and the Makati Medical Center, for their valuable support. This is Dr. Pauline Santiago, together with Dr. Selly and Dr. Domingo, and the UP Med webinar team. We are closing this session. We hope you have learned a lot from today's webinar and join us again on our upcoming webinars. Have a great week ahead. Thank you.